Thank you so much for inviting me. I'm delighted to be here. I have a lot of material to go over. I'll try to skip over the background as I was asked, and I'll try to leave as much time as possible for questions. Just briefly, I present this slide when I have to talk why about ketamine, what's about ketamine, because we get continuously hundreds of inquiries from patients with severe depression, from colleagues. The main point, it's not magic. There's a significant level of hype in the media, and patients and clinicians alike keep asking, is another fad? Is it real? Should my patient get ketamine? When is time to recommend it? Can I start prescribing ketamine in my office right now? Can the patient get it at the local pharmacy? This patient does not want any medication, but he wants ketamine. Is that okay? And the patient has been depressed for 50 years. Do you think 1 or 2 infusions would be enough? This was the level of questions that started our research on ketamine. And you're all aware about the acute efficacy data. This is just a summary: major depression in bipolar, even versus midazolam. Ketamine still maintain a significant advantage by day 7 in terms of reducing depression severity. And a number of meta-analysis and Cochrane review have supported, as you can see, the efficacy of ketamine. Then there are those studies, those are the skeleton for a trial planning to enroll 19 subjects. And the design was published in 2018. We're still waiting to see the results for acute effect of ketamine. Bottom line, in the United States, there are hundreds and hundreds of ketamine clinics offering these treatments to desperate patients in US. I suppose, I'm not sure what's the situation on the other side of the Atlantic, but this is what we're dealing now. Just a brief background again, Massachusetts General Hospital is a tertiary care center. The psychiatry department at over 600 faculty. We have about 50 subspecialty centers: depression, OCD, PTSD, Tourette, cognitive disorders, and so forth. So think about which kind of patients get referred to the super specialized depression center of a tertiary care hospital in the United States. Frustrated by my lack of ability to enroll any of my patients in research studies, I started designing trials for my population. Together with colleagues from anesthesia, we tried initial case series of patients treated with 0.5 milligram per kilogram, because that was the dose that everybody was using. But if we did not see any result in this very treatment refractory population, we thought, why not trying a little more? And we seem to have some additional response after escalating the dose. So we were part of a multi-center study comparing 5 different doses of ketamine versus midazolam, again, single infusion at day 3. All the ketamine doses performed better than midazolam, but the doses that seemed to be doing better were 1 milligram per kilogram and 0.5 milligram per kilogram. So we started thinking, maybe there is something about the dose and about the timing that we need to learn more. And then the major question from the patients was, how long is a ketamine treatment? There are no rigorous long-term data besides registry on esketamine from Janssen, some case series from us, from Yale, from Emory. But if you think about depression, similarly to other medical conditions, if you have a young patient with intermittent disease and long intervals between episodes, it's easy to hypothesize the patient can have a very short course of ketamine and do fine for maybe years, because that's the natural history of the disease. But if you have patients who have been chronically ill for 5 or 10 years, like the majority of patients in our clinic, you see they do relapse whenever they try to stop ketamine. So this is a difficult answer. We decided to do a retrospective study because it was extremely complicated to do an IRB study. The FDA would not allow to study variable dose, variable frequency of ketamine, and we were focusing all our energy in starting the clinic for those very desperate patients. This was the report we published about the first year of operation of the clinic. We enrolled 87 patients. You can see the average age was in the mid-40s, but the range was from 17.5. We had special permission from the Department of Child Psychiatry to treat patients under 18. We had just a couple up to age 81. There was no upper limit. 55% female. Most of them were highly educated. I will say college professional degree was the majority of patients. 48% about 50-50 single or in a relationship. I would say 35% employed full-time, 6% part-time, and a good number of students that were primarily children of staff members at the hospital who heard about this. We do not advertise for the clinic. We are not trying to recruit for the clinic. It's mostly word of mouth. High level of comorbidities among the patients. You can see patients with full-blown GAD, PTSD, although I suspect the PTSD rate is a little higher. OCD and ADD are highly comorbid with our population. And the duration of the episode was the mean was 6.7 years plus minus 11. So there were patients who were sick for almost 20 years, this current episode. 30% had a history of suicide attempts. The average number of antidepressant failed lifetime was 7.4 plus minus 3.7. 33% had a history of failing ECT, 28% had failed TMS, and their average CGI score was 5.2. The average QID score was 17, putting them in the severe depression range. Keep in mind that the clinic for the first year was completely self-pay. This is a rapidly evolving situation, rapidly in quote, but Blue Cross Blue Shield, the major payer, just agreed to cover the infusion and to cover Spravato in September of 2020, even if Spravato has been available on the market since March of 2019. So IV ketamine is currently self-pay only, except for the patients with Blue Cross Blue Shield. And we recommend that course of 6 infusions in 3 weeks, followed by monthly maintenance infusion or whenever there is a drop in mood. Intranasal ketamine is available as self-pay, but we tend to transition patient out of intravenous if they cannot come because they live far away, or if they have serious challenges with affording the cost of the ketamine, but they have experienced significant benefit. And we can talk more about the logistics of the clinic if you want. So the efficacy data presented in our paper, we had 85 patients who were ketamine naive, and we had for whom they agreed to fill up the QIDS depression rating scale self-rated. 70% of them completed the 6 infusions recommended as initial induction phase. And 27% discontinued. 3 at the time of the analysis were still in the induction phase. And the reason was mostly insufficient improvement. If you reach infusion 3 or 4 and you've seen 0 benefit and some side effects, you tend to drop out, especially if this is costing you $550 per infusion, plus parking, plus transportation, plus all the logistics. So patient really disliked the dissociative symptoms, severe nausea, or they just did not tell us why they were dropping out. Our response rate was about 18.3% in this initial sample. We have an additional analysis of the following 10 months and did not seem to change much. About 35% were improved by 35% or more, so they didn't quite reach the cutoff of 50% improvement on the score. And we can talk more about why we thought this was important to report. However, about 50% of patients decided to continue to pay the same amount of money for infusion, and they transitioned to maintenance. They continued to come to the clinic because in their perception, the level of benefit was sufficient to continue to receive. We try various analysis of covariate age, sex, employment rate, and the bipolar sample was really small. Psychiatric comorbidity, history of suicide attempt, none of the various clinical variables we try to analyze were associated with the likelihood of responding in terms of QID score. How did we explain it? Our response rate to intravenous ketamine is significantly lower compared to the rates if you the Yale people, they make fun specifically of me, telling that it's all my fault that I don't know how to treat patients, but it's a joke. We have a very good relationship when we constantly exchange and communicate about difficult cases, but their patient population is different. Our response rate is even lower of the Yale case series. That they had a 45% response rate for infusion protocol at a fixed dose. Our dose was scale prior to each infusion. So it's at the lowest point of the dropout and not a pre-specified. So if the patient is doing well for about a month, we administer the quit score when they come for the visit because they have relapsed. So that's the lowest they have been in the previous period of time. And that's a problem we're trying to address with sending questionnaires and assessment via email and trying to follow up with in-person assessment at regular intervals instead of when they come back for a dose infusion. And also the very high dropout rate may be driven by the cost of ketamine infusions not covered for a lot of the patients. We were a little bit reassured when the Canadian data was published in the Journal of Affective Disorder. Those are 213 patients, similar average age, bipolar or depressed, lower level of antidepressant resistance, and the dose was variable between 0.5 and 0.75 milligram per kilogram. Their response rate, considered 50% improvement, was 27%. And the remission rate was 13%. They noticed the effect on anxiety, the psychosocial function, they reduced the suicidal ideation. So the other question I hear over and over from my colleagues is it safe? Is it safe to keep giving ketamine to these patients? We have conducted over 800 infusions since the opening of the clinic. About 5 were discontinued due to adverse event. 1, the blood pressure increase and required labetal of 5. Otherwise, we have never had to administer any antihypertensive agents, and we just watch the patient within 30 minutes, the blood pressure goes back to normal. We don't treat any patient if they have severe hypertension, uncontrolled hypertension prior to coming to the clinic. 3% of patients dropped out because they really disliked the dissociative experience, as I mentioned before. Nausea is very, very common, treated with mostly ondansetron, and during the infusion are common dizziness, sedation, dissociation. The day post-infusion can be common headache, nausea, insomnia, or fatigue. We haven't seen any problem of persistent side effects. We haven't seen a urinary problem in 2 years at the clinic, no new onset of psychotic symptoms. And we had 1 case of severe dissociation in patient with PTSD who chose to continue to come to the clinic because the depression was so improved, and the level of dissociation did improve over time. Suicidality, we had 67 patients with a suicidal ideation score more than 0. 18% reached complete absence of suicidal ideation by infusion 6, and 37% decreased the level to by at least 1. We had 1 patient who committed suicide 10 days after the 4th treatment of the series, possibly severe life stressors. The suicidal score had decreased from 2 to 1 on the quiz. We are not sure what led to the long interval between he was supposed to come for the 3-week, twice a week series, but he decided to delay for unknown reason. And we had 1 patient attempting suicide after observing complete lack of improvement, becoming severely hopeless after the 6th infusion, the day after, overdosed on her medications and ended up in ICU, but luckily survived. Just to remind you who gets ketamine at MGH, they must be referred by the treating psychiatrist. We don't accept any self-referrals. Severe depression, ECT is being considered, suicide risk, significant mood or suicide symptoms, symptoms known to be responsive to antidepressant for maintenance if they've been doing well, no major medical issues. We have ongoing discussion with the clinicians about the exclusion for ongoing substance use disorder. We don't treat anyone with a history of primary psychotic disorder, unstable medical illness. And again, we can debate about that. And if there is no psychiatrist involved, no escort available for transportation, or the patients do not provide access to medical record, urine tox screen, or release to talk to the psychiatrist. And then the dilemma is always when the number of treatment failure is sufficient to try ketamine, and us to try a few more. You need to balance the acute need for relief versus keeping a rigid rule about the number of past treatments failed. Then we start receiving requests for patients with advanced cancer, patients with mild cognitive impairment, mixed state, and we don't have an answer for all those questions. Changing medications. At the beginning, we were tapering off a lot of the other medications, especially benzodiazepines, and then everybody was developing panic attacks prior to receiving ketamine. That was a disaster. We try to decrease the doses as much as possible, but often it's not feasible. Lamotrigine, not for every patient, but for some patients seem to interfere with the effect of ketamine, and we haven't observed anything with naltrexone. And after the 6 infusions, what do? I've been trying for 2 years to sustain the effect of ketamine with anything you can think of, and I've not been successful. So the only thing that seems to be working is to continue with regular ketamine infusions, possibly some signal for lithium in bipolar. I haven't seen any signal in MDD. So the chances of responding becomes a debate with the patient. On average, maybe 50-50. Even post-ECT failure is still pretty high, but you need to have a plan B ready from the get-go, especially for patients with extremely treatment-refractory depression and suicidal ideation. And being rejected for ketamine treatment is a major deal that needs to be discussed with the team meeting, and it's a very long process as well. We discussed about the side effects. We had one asthma attack in patient with known asthma and prior allergic reaction to anesthetics. Otherwise, we administer typically ondansetron, lorazepam, some acetaminophen. Long-term side effects still unknown. We have constant fear of some potential long-term side effects we can't foresee yet. And there is some anecdotal tolerance for high dose of intranasal. We haven't seen tolerance with IV yet, but it's always a possibility. We have an extremely long wait list. We see a few patients because they're so time consuming, and it's extremely complex patients. They have multiple psychiatric comorbidities, they have mood fluctuation, they have acute relapses. They're very difficult. They require a team effort to take care of them. And the major problem is that about half of the patients felt better with ketamine for the first time in years. They feel better for a short period of time that is proportional to the treatment resistance. The higher the treatment resistance, the lower the duration of the effect of ketamine. And then they become again severely depressed and suicidal. So the improvement in symptom does not translate in functional recovery. And we work with the CBT team. We work with other colleagues trying to figure out how to treat those patients. We're trying to develop other type of interventions, CBT specifically developed for patients on ketamine, other forms of support, a rehab center, and we're starting a center for neuroscience of psychedelics to figure out what to offer to those patients. Thank you very much. This was the presentation. I'll be happy to take questions.
Cristina, thank you very much. There's lots of questions flooding in already. Let's just crack on with these. Was there a difference based on dosing in terms of the response rate?
It's a tough question because if you don't see response, if you don't see any benefit the day after or 2 days after a certain dose of ketamine, we just try to go higher. And for some patients, it does make a difference. So we're now going from anywhere. I don't believe the milligram per kilogram is the way to go. I think the total number of milligram makes more sense, but we're going up to 1.2 milligram per kilogram, which translates in an adult up to 140, 150 milligrams of ketamine IV administered over 40 minutes. And for some patients, it's the only dose that works. So we can go back down.
Do you think that the use of the QIDS SR might explain the lower dose rate than many of the other studies? Is there something about this scale?
I think that the scales that we're using in clinical trials are woefully inadequate for capturing changes in this population. I have a lovely patient. She's also part of our advocacy and our development office sort of members. She went back to work as an attorney in private practice. Her QIDS did not move from 22. So that there's a complete disconnect from the level of practice. She hasn't worked in over 10 years. And then despite her level of symptoms remaining pretty high, her level of function was increased in a dramatic way to the point that opening her own private practice as an attorney and being successful at it. So there's and I think we would have seen the same problem with MD or MADRS or other scale that are designed to detect changes in patients with intermittent disease. So they were functioning at a certain level, they had a drop, and then you bring them back, not in patients with a chronic condition, unrelenting depression for a decade. They're not sensitive enough.
Thanks.
Can I ask a follow-up question on that? If I'm not mistaken, from the paper, you were also collecting the CGI. So did you notice any change, for example, when you were using like a clinician perspective?
The CGI is improved, but the patients continue to complain of symptom of depression, the hopelessness, they had an anhedonia, sort of low level of suicidal ideation does not go away. Yet their functioning improves so much, so that there is the need to develop better skills to capture changes in this population that we don't have better instruments.
You don't think an area under the curve would be better if you had daily mood monitoring and took an area under the curve? That's what we're interested in. Might be.
Let's talk about that.
I've got a question from Cone, which I'm going to paraphrase. And did you notice any less effect in your older patients, or any difference in the very young patients?
Very young, we have a handful of college students who are doing phenomenally well. There's nothing like a young brain to respond, go back to school, come back once every 6 weeks for an infusion, and then you don't hear from them until the 6 weeks is up. So the younger patients are the prime candidate to just recover functionally and symptomatically. Above age 65, I have to say, I may have 1 or 2 cases of patients coming for maintenance, but in general, it's been extremely disappointing.
Okay. Do you think that, I mean, there's a question here about biomarkers, and obviously we'd all love to have a biomarker that predicted response, and so that we could say to patients which, you know, particularly to exclude patients, I think it'd be very helpful. Do you think EEG and machine learning might offer a way to that biomarker?
The problem with EEG, we've been trying EEG, there's a lot of noise that's confounded by the acute side effects. And I think that there's a noise primarily. There are phenomena of dissociation that are not terribly related to the antidepressant effect. So it's really difficult unless you capture serial biomarkers throughout the time, even when the patient is not at the clinic and not getting an infusion, to see how the parameters fluctuate over time and correlate with the symptom. We are stuck with having very narrow window in phenomena. We don't fully understand what happens during infusion. I think there is a lot of other things happening, and they're part of the dirty pharmacology of ketamine and not necessarily related to the antidepressant effect.
Okay, thanks. So we've got a question from Jennifer Swainson about dosing intervals. And in particular, do you think that this monthly rate is enough? And I see that you're giving people IN ketamine to take at home. Presumably they could take that at a shorter interval than these infusions. And do you find that they are better maintained using that shorter interval?
If the costs are not a barrier, some patients come every 2 weeks. If insurance pays for it, they tend to relapse around day 13, 14. So they come. The interval is exquisitely personal. There are patients who can get 1 infusion and stay well for 5, 6 weeks, and they're usually not that treatment resistant. And patients who after 1 week from an infusion, they drop. And with intranasal, it's variable between 2 and 4 days, but the intranasal absorption is much less predictable and can be altered by nasal allergies, by upper respiratory infection, by a bad batch of ketamine, because the quality of the product is certainly not the same as Spravato. There are a lot of variables, so just the timing of administration is not sufficient to induce someone into remission and keep them there.
Okay, can you say anything about intramuscular administration?
Intramuscular work, especially when patient has been very helpful. Again, all the vials are not created equal, and the stability of the product, I don't know if because of shipment or other issues, is not the same of having an infusion at the clinic, but it's better than nothing. So it's patient dead versus an imperfect way of keeping them sort of out of the depression and alive. So that we have used visiting nurses, we have used different way to administer, and it's on average every 5 to 7 days, one infusion, what they responded to in the clinic.
Cristina, I'm just going to ask you to say that again, because you broke up as you were in the last part of your answer there. So could you just repeat that?
So during the pandemic, when the patients had serious trouble in coming to the clinic, we have been using intramuscular for maintenance at the dose similar to the dose they were responding to for intravenous, and the frequency is significantly higher because it's every 4 or 5 days to every 7 days, one injection. We've been using with visiting nurses and other professionals to administer it to the patient. But the stability of the vials throughout the pandemic has not been good. It's been much lower, the ketamine compounded, the quality of the product of the ketamine compounded during the pandemic has been awful. Okay.
The first question we had was about the interaction between Spravato and IV ketamine and which should be started first. And I'm going to ask a supplementary. Have you had people who've come in on Spravato and wanted IV top-ups?
Not top-ups, but they want to cut down on the number of visits because it's 3-hour visit twice a week or once a week. If you're trying to hold on to a job, it's not trivial. It's not a trivial number of hours if you need to arrange for childcare or transportation or coming down to the clinic downtown and park downtown. And it becomes a 4 or 5 hour enterprise. And it's really cumbersome for some patient, while infusion is maybe an hour and a half. And if it can become once a month, it's much more convenient. But it's mostly been driven by insurance reimbursement.
Okay, thank you. The doses that you used in the maintenance phase were stable. Yes. They didn't go up. You said that you didn't have tolerance, but yet they were relapsing. There were times when they relapsed. Do you think that any of that relapse might have been simply that they were becoming tolerant, and if you'd used higher doses or more frequent doses, that would have done the job?
Often, because life continued to happen, if there is a major, if there is a life event, for example, a lot of the patients have comorbid PTSD. If they have a PTSD flare, the ketamine seems to work a little less. So you need to maybe to do a couple of infusions, but at the same dose. Usually, if you go above a certain threshold for each patient, it becomes more of an anesthetic, and they just don't get any benefit. It's not that there is a linear curve. If you continue to go up with the dose, you improve the response. You reach a point where you just have a ton of side effects and sedation and no antidepressant effect, but it varies for each patient.
The question about comorbidity: is ketamine an optional treatment in personality disorders patients that don't respond to other antidepressants?
That requires a very long and winded question. In the very short version of it, I'm not sure if I believe what a personality disorder. I need to see that someone meets criteria for personality disorder outside of being severely depressed, which is nearly impossible to see if somebody has been depressed for 10 years in a row, starting at 12. So I have a lot of patients who came with a diagnosis of borderline personality disorder that disappeared once the Axis 1 was under control. So I say, why would you deny ketamine as an option just to see what's underneath the depression? And then you figure out how to approach it.
Okay, we're going to have just 2 more questions, I think, because we're running over this, but we're not going to get through them all. But anyway, this next one is, given the increasing published evidence of for parenteral ketamine for a variety of substance use disorders, why exclude these patients?
Because we don't have, mostly because we don't have the expertise and the team. They're complicated enough if they have medical comorbidities, multiple psychiatric comorbidities. We have CBT therapists, we have depression experts. If we're able to recruit someone with also the expertise to manage the substance, but they need so much more than what we can offer now. They need peer support, they need a counselor, they need an IOP. We're not at the level where we can offer a comprehensive type of treatment. We feel we're not well equipped to treat those patients at this point in time.
And I'm going to have the last question, if I may. I saw that you run your clinic in the evening from 5:30 to 8. Tell us about your staffing and the numbers that you get through, and also a supplementary question: how many patients who are referred to you do you actually say no to?
So let's start with the last part. We turn away maybe 10–15% of patients because of lack of engagement of the providers. If the primary providers are not responsive, we cannot take patients on our own. We just don't have bandwidth. We can treat up to 12 patients per night. And this was the cheapest place that MGH would let us use by charging us a decent rent. Any other place for an infusion clinic would have been so ridiculously expensive that each infusion would have costed the patient $1,200 a pop. So this was the cheapest place we could find anywhere in Boston downtown that MGH would let us use. So we have 1 anesthesia on call, 2 nurses, 1 or 2 psychiatrists, 1 fellow, and 1 medical assistant.
Well, there we are. That's fantastic. Thank you very much indeed. Thanks to the audience.